I would like to thank the scientific committee for this invitation. I hope my talk will help you in your practice, especially for chronic abdominal pain in children. First of all, I will give you a case scenario similar to the adult, but in this chance it will be pediatrics. Then briefly, what's the epidemiology, the causes, pathophysiology, and the management. You have seen 11 years old healthy boy with experience recurrent abdominal pain for 6 months. That child described this pain is periumbilical, occurs 3 times a month, variable in severities, doesn't interfere with his activities, and no nocturnal symptoms. He described it is associated with nausea and anorexia, and he missed 10 days school, but he has normal bowel habit. On physical examination, usually in children, we are responsible for a growth chart, and if you see the growth chart is normal, has normal examination, and he has normal lab, including CBC, platelet, ESR, and urine analysis and stool analysis were unremarkable. So this is 11 years old with recurrent abdominal pain for 6 months, otherwise healthy exam and normal lab. So what's next for our approach? Usually in pediatric, the common cause of recurrent abdominal pain is functional abdominal pain. Then constipation can the next, parasitic infection, another cause of recurrent abdominal pain, renal disease, helicobacter, celiac, and others are less common, while eosinophilic enteropathy, malignancy are rare causes of recurrent abdominal pain. We usually remember fecal loading or chronic constipation is very common in children, while in this X-ray with fecal load, it's almost like fecal load of this car, and most of the parents describe this constipation is decreased by bowel habit, which is not usually. If the child describes he has hard lumpy stool, it is constipation. If the child describes he has painful, only one symptom, it is constipation. And if the child describes that incomplete sensation of bowel habit. So remember, constipation is very common cause of recurrent abdominal pain. So there are no diagnostic tools to distinguish between functional and organic abdominal pain. However, similar to the adult, we have red flag signs, but it's a little bit different. One of the most important is nocturnal abdominal pain. Others, like bilious vomiting, pain away from umbilicus. The most important of red flag in pediatrics, we call it growth failure or growth retardation. If the child is not growing well, not doing well, rebound tenderness, perianal disease, and increased biochemical markers of inflammation. So back to our case. We diagnose functional abdominal pain. We reassure the parents. We give psychosocial support. Sometimes lactose-free diet may help, and high fibers may help, and follow up 3 months. 8 months later, the parents who are extremely anxious believe there is ongoing problems, abdominal pain getting worse. You lose weight because of the anorexia and fearing of the pain, and no improvement of antacid. You repeat the exam, we're normal, and we repeat lab, and you discover he has mild anemia with hypoalbuminemia. Otherwise, the celiac screen were negative, H. pylori is negative, and the radiological findings were negative. So we diagnose what we look, and we look for what we know. This is why when you order test, we should know what we are looking for. Our patient has no red flag. We diagnose functional abdominal pain or dyspepsia, abdominal pain getting worse, then no improvement with anemia and hypovolemia, so the next approach will be either endoscopy or abdominal CT scan based on the individualized person. So we did endoscopy, shows antral nodularities with gram-negative organism, and we diagnosed him as Helicobacter pylori gastritis. He responded to back treatment and no more abdominal pain after 8 months. Regarding the definition of abdominal pain, according to the American Academy of Pediatrics and NASPGHAN, they define as 3 episodes of the pain over 3 months with the pain sufficient enough to affect his activities with no organic causes. It is diagnosis of exclusion, and usually it's combination between history and physical examination. 2 to 4% is account to pediatric visit. However, the school children account for weekly abdominal pain, and most of these children, 70% of them, they did come to the physician or attention and came for seeking advice. We have Saudi data. Al-Muzan did a huge number about the gastritis, and he found that abdominal pain account for 45% of gastritis, and he found that abdominal pain is common in adolescents rather than the 5 years of the age. Regarding abdominal pain, 90% of them are non-organic, while 10% are organic. Imaging studies, hydrogen breath test, and motility studies are responsible for 10%. However, IBD, celiac disease, peptic ulcer can be presenting as organic cause of abdominal pain. And if you see this cartoon, the functional bowel disorder in children, usually the recurrent abdominal pain in childhood account between 2 years until the adolescence. So once the older child, similar to the adult abdominal pain behavioral. There are 35 pediatric gastroenterologists working team for Rome 3 criteria, and they classified these abdominal pain as functional disorders, and they label him as 5 categories: either functional abdominal pain, or functional dyspepsia, or IBS, or abdominal migraine, or functional abdominal pain syndromes. Usually, the commonest is functional abdominal pain, and it comes with the upper GI symptoms of bloating, usually will be dyspepsia. If the child has alternating similar to the adult with the bowel habit, usually we label him as IBS. And if there is any family history or maternal headache, usually abdominal migraine. If you didn't find the 4th, usually you label him as functional abdominal pain syndromes. And most of these are IBS. However, migraines and dyspepsia accounting to 25% to 8%. Regarding the pathophysiology of the recurrent abdominal pain in children is unknown, but usually we explain to the parents there is multifactorials, including motilities, sensory, and psychology interacting between these, causing neurotransmitter imbalance and spasm. And we usually explain there is a little pain in the gut and no need for medication, and it will dissolve. There are some little clue for primary care physician. If you have abdominal pain, just go from up to down, and if the child has any respiratory symptoms with suspicion of vomiting, you suspect GERD. If the child has blood stool, weight loss, IBD, sometimes constipation can be severe enough to wake up sleep. Lactose intolerance and biliary pain aggravating by food can account for abdominal pain. And as I mentioned in growth chart, this is the weight. If drop, it means the child has organic abdominal pain and you need to do extensive workup. What's about the approach? If you have a child with recurrent abdominal pain more than 3 months, After taking history and physical examination, just categorize the pain. Where is it? Is it the pain alone? Is it with altered bowel, or with dyspepsia, or with cyclical pain? If it is, just search for alarming or signal or red flag signs. If there is, evaluate further. If it is not, your working diagnosis most likely will be functional abdominal pain. If it comes with the pain, we label him as functional abdominal pain. If with the altered bowel, we label him as IBS. If it is with dyspepsia, we call it functional dyspepsia. If the cyclical pain, usually we label him as abdominal migraine. And the first line blood work usually is CBC, stool for occult blood, celiac screen, sometimes if it's available lactose breath test, and helicobacter screen and radiological studies. After that, initiate treatment, 4 weeks follow-up, just depends on the lab result, assess the response and reinforce the diagnosis. This is our practice in pediatric and even in pediatric etiology if you have a child with abdominal pain for this algorithm. Just quickly about the evidence or rating of evidence quality of recurrent abdominal pain. If it is A, usually it is 2 RCT. If it is B, usually 1 RCT, and the last will be expert. Regarding the predictive value of the history items, we label him as rate quality C because the pain severities, location, effect on lifestyle doesn't distinguish between organic and non-organic. Regarding the lab, usually the evidence quality is D, still low, because there is no evidence to evaluate the predictive value of the blood test, even if you have alarm signal. Regarding other diagnostic tests, there is little evidence about abdominal ultrasound, endoscopy, and biopsy, and pH probe to distinguish between organic and non-organic cause. Regarding the treatment, generally we emphasize that the most common cause of abdominal pain is childhood. Usually we don't scare the parents that this is a cancer or this is obstruction. We reassure them, drawing pictures that this is normal like growth or development, so since you don't have red flag, just reassure them. And that pain is real, and usually the condition may result from developmental variation of the pain threshold, and the condition usually explained to them if this is self-limited, and both parents must support the child rather than supporting the pain, and the lifestyle may be normalized, and that approach should be enhanced by return visit. The principle of recurrent abdominal pain, usually it is kind of interaction between physician and patient, some relaxation technique, and you may have a trials to give lactose-free diet, fibers, and avoid food that trigger flatulence, and trial of medication like laxative and antispasmodic. However, if you go to the evidence-based medicine, most of these are evidence B. So lactose-free diet, fiber supplement, peppermint oil, H2 blocker, and behavioral treatment, all of them are inconclusive evidence to decrease the abdominal pain. Klein did a nice studies in a randomized double-blind control trials for peppermint oil in 42 children with IBS, and he found that there is a benefit effect in reducing abdominal pain with small muscle relaxation. However, H2 blockers plus or minus PPI, it may help with the dyspepsia for studies for 25 children within a small, but it was significant improvement of H2 blocker in dyspepsia symptoms. Lactose-free diet to treat children with recurrent abdominal pain, Again, Lebenthal studied 100 old children, and 38 of them received 6-week trials in double-blind fashion, and the patient was then placed on 1 year of milk elimination diet, but there is no effect on outcome of abdominal pain in lactose absorber and non-absorber. However, in our practice, and even in tertiary care centers, usually they give analgesia. Usually they give antispasmodic, sedation, laxative, and propotics. There is no much evidence of the effectiveness of abdominal pain, and once you reassure the parents about the natural history of the pain, usually they respond. However, based on the result I explained, it may help in some children. What's about the prognosis? The prognosis, usually 40% of the children experience the pain as adulthood, which is a large number because most of these children diagnosed in older or adolescents, so there is no much time. And 30 to 50% of these patients, they have resolved symptoms by the treatment or after the diagnosis by 2 to 6 weeks. However, usually the female has better prognosis. If the age of the onset more than 6 years is better prognosis. If the symptoms duration less than 6 months is better duration. And sometimes, which is facing the problems about the painful family. Usually if you have painful family, you will have painful management and you are struggling with this abdominal pain, and they conclude this is as a worse prognosis. And some of the operation like appendectomy, hysterectomy, they have worse prognosis for abdominal pain. Rapport did long-term studies that the outcome of the recurrent abdominal pain after 5 years of the diagnosis, 1/3 they have resolved abdominal pain, and 1/3 they have the same symptoms, and 1/3 they have different recurrent abdominal pain, changing from abdominal migraine to functional dyspepsia as the 5 categories. So my conclusion, recurrent abdominal pain is defined by combination of 3 episodes of the pain over a period of 3 months, plus pain sufficiently to affect activities, plus unknown organic cause. Functional abdominal pain is the commonest cause of recurrent abdominal pain. 90% of recurrent abdominal pain is by non-organic, and the effectiveness of pharmacological treatment, including fibers, lactose-free diet, beta blockers, peppermint oil, and behavioral therapy, is inconclusive evidence. However, 40% of the children who have functional abdominal pain experience adulthood abdominal pain. I would suggest for primary care physician 2 articles summarize briefly. This is from NASPGHAN, North America Pediatric Gastroenterology and Hepatology. It will give you the practice guidelines of chronic abdominal pain in children, and in Gut Journal they give primary care physician approach to functional abdominal pain in childhood. Thank you very much.